Good evening and welcome to the University of Tasmania's Island of Ideas public talk series and the 2025 Arthur Cobbold Memorial Lecture. I'm Professor Ruth Kieron and I'm the head of the Tasmanian School of Medicine, and it is my great pleasure to host this evening's talk, The Decisions That Shape Our Health. We meet tonight on Lutruwita, this beautiful island of Tasmania, on the unceded lands of the Palawa people. Here in Nipaluna, Hobart, beneath Kunyani, Mount Wellington, we pause to recognise a culture that has always understood health in its broadest sense, the health of people, of community and of country. As we reflect on how decisions shape health today, we reflect on their deep history of care, connection and resilience. We pay respects to elders past and present, to those who did not make elder status, and to all Aboriginal and Torres Strait Islander people who join us tonight. Our university stands for a future that profoundly respects and acknowledges Aboriginal perspectives, culture, language and history, and we are committed to playing our part in building culturally safe health services. If you are joining us online tonight, we invite you to share your acknowledgement using the Q&A function. This lecture is part of the Island of Ideas series, a program that opens the university's doors to big conversations. It brings together researchers, practitioners and community voices to ask questions that cut across science, policy, culture and lived experiences, because the challenges we face never sit neatly in one box. Tonight's annual lecture honours the late Professor Arthur Cobbold, the University of Tasmania's founding Professor of Physiology and Dean of our medical school for 13 years. When he came from England in the 1960s, he believed Tasmanians deserved the chance to study medicine here in Lutruwita, Tasmania, and to practice it for their own communities. This notion of place-based and socially accountable medical programs is one which is very much alive in the Tasmanian School of Medicine today, as we extend to the opportunities for Tasmanians to study medicine in all three regions of Tasmania, not just here in the south. Professor Cobbold began his academic journey in chemistry at Nottingham and then discovered physiology, which is the study of how the human body works. He became so passionate about it that his first students went on to complete physiology degrees themselves and become professors. And this is despite him not having a physiology degree at the time. Having completed his PhD at St Thomas Hospital Medical School, he rose quickly through the ranks, but chose Tasmania to help establish a new medical school. Professor Cobbold is remembered as an outstanding teacher, researcher and administrator, but also as someone deeply committed to the community. For Cobbold, medicine was never just about the classroom or the laboratory. It was about systems, policy, politics and people. That's what makes tonight's lecture such a fitting tribute. Tonight's Arthur Cobbold Lecture is about more than just medicine. It asks us to consider how health is shaped by the decisions made around it, and it explores how those decisions are shaped and made. How do we really listen to our communities and allow them to have a voice in shaping the decisions that impact on their health, including shaping the education and training of new health professionals? In an age of misinformation and disinformation, how do we ensure that the decisions that shape our health systems are informed by science? And what benefits can be achieved by incorporating Indigenous knowledges into the decisions that shape our health systems? The entrenched structures of the health system, the choices of governments, the possibilities of new technologies, and the way we prepare the next generation of health professionals have a direct impact on the health systems that we have. And the directions of these decisions affect every Tasmanian, whether you work in primary care, in a hospital, whether you run a health service, or simply want to know that your family can rely on good care when they need it. Our guide this evening is the Honourable Lara Giddings, AO. Lara is known to many as Tasmania's first female Premier, but her story has always been one of a commitment to health. As Health Minister, she introduced the state's first comprehensive health plan, which importantly considered the role of prevention and primary care alongside the acute hospital system, working to reform the system in ways that could meet both immediate pressures and long-term needs. Since leaving that Parliament, she has continued that work. Now Chief Executive of AMA Tasmania, she also serves on the boards of Salvio Healthcare, the Festival of Voices and the Hush Foundation, bringing her voice to the intersection of health, community and creativity. This breadth of experience makes her uniquely placed to explore the theme of tonight's lecture, Few people understand more clearly how the decisions taken in politics and policy ripple through health services and homes across Tasmania. Please join me in welcoming the Honourable Lara Giddings, AO.
Well, thank you very much, Ruth, for the introduction. And I too acknowledge the land of the Muwinina people of Nipaluna and the broader Palawa people of Lutruwita. I pay respect to their ancestors, their elders, and to all in the Palawa community here with us tonight and also across the state. In health, we talk about healing, acknowledging European invasion and our impact on the original inhabitants, the owners of this land, is part of the healing for this vulnerable community. And I hope this acknowledgement helps. Good evening to all of you, and thank you so much for taking the time to be part of tonight's Cobbold Lecture. It's no mean feat coming out on a night like tonight, where I believe there could be hail, storms, and so on. So thank you for making that effort. Whereas once I was speaking in one fora or another on a daily basis, these days I seldom get the platform to just stop and reflect on the past, consider the future and espouse my views. So while I don't miss the political fray, I do miss being part of the public discourse. And thus, when Ruth asked me, would I be part of tonight's lecture, I jumped at the chance. I must say, though, having then had to put the blood, sweat and tears in pulling it together, I said to myself, never again. I'm not doing another one of these lectures. But it's great to be part of a series that does honour one of our health forebears, a man who did so much for medicine and for developing the medical workforce of our state, Professor Arthur Cobbold. Professor Cobbold was not only a foundation professor of physiology and long-serving Dean of Medicine at the University of Tasmania, he was one of the most admired and much loved medical educators in this state. He challenged his students to think beyond the science of medicine, to consider how they could shape systems, influence medical thinking, and contribute to the health of the broader community. His legacy lives on not only in the generations of doctors he taught, but also in the ethos of inquiry, service, and leadership that continues to shape the profession today. As mentioned by Ruth in her opening remarks, it is fitting, as a former Minister for Health, to be giving this lecture some 40 years after Professor Cobbold said in his interview for the National Archives that he'd spent much of his time throughout his career, quote, arguing with the Minister for Health. So to stand here as a former minister and now a CEO of AMA Tasmania, working every day alongside many of the doctors who were fortunate to be one of Professor Cobbold's students, makes it an extraordinary honour to take part in this lecture series that bears his name and honours his legacy. Tonight, I will speak about my life as Health Minister from 2006 to 2010. And through my story, I hope you will leave with a better understanding of the realities and compromises in politics that shape our health system, for good or ill. For politics is about the art of the possible and balancing competing priorities. And while no longer in Parliament, but a newly minted CEO of AMA Tasmania, I will also look at the impact of COVID-19 and the impact of disruption on health reform. Recognising the circumstances of the day will always shape what is possible in health. And finally, I will talk about the future of health, what lies ahead for medicine, and how we prepare future medical leaders for an era of robots, AI receptionists, and ChatGPT diagnosis. To influence the future of health, medical leaders must understand politics, engage with policy makers, and embrace new technologies. And at this point, I do declare that conflict of interest that Ruth mentioned in her opening remarks, that I not only work for AMA, but also sit on the board of Salvio Healthcare, a not-for-profit company established by St Luke's Health to deliver health services outside of acute hospitals and within people's homes. From the age of 3, I've been interested in people and the role of government at looking out for the vulnerable. It began with the Whitlam dismissal in 1975. After nearly 22 years of Conservative rule, followed by just 3 years of transformative Labor government, my mother took to bed for a week in grief as Whitlam was forced to an election he would lose. That short reforming period laid foundations for modern Australia, including Medibank, the universal health system that evolved into Medicare. And it shaped my belief in what politics can and should do. My parents came from different worlds. My father, a country Victorian banker's son, leaned Liberal Conservative. My mother grew up in hardship, the poor child on a street where other families had cars, fridges, vacuum cleaners and washing machines. Her mother cut the lawn with scissors, kept food cool in a Coolgardie safe, used an old copper for washing clothes and a dustpan and broom to sweep the floor. Their competing values made for lively dinner debates, and my sister and I watched, heads turning like a Wimbledon crowd, as each argued their case. Around that table, I learned the art of debate, and I formed convictions that I still hold to this day. Opposition to capital punishment, support for LGBTQI+ rights, and voluntary assisted dying. I might also add, though, that my dad was my biggest fan, and you'll see there in that image, that is his group of scrapbooks that I have used to reach back into history for tonight's talk. So thank you, Dad. Growing up in Papua New Guinea sharpened my sense of inequality. In Goroka, where I was born, I knew people who lived in villages. Their round bush houses had straw for roofs and dirt for floors. They had no running water. Cooking was done over a fire. Fresh meat was for special occasions, cooked in a mumu. Sweet potato, tinned fish and rice forming their everyday staples. Meanwhile, I lived with meat and 3 veg each night, warm beds, flushing toilets and a hot shower. While the new Goroka Hospital, where I was born, was relatively modern, the wards were nothing like our Australian norms. By year 11, a visit to Canberra sealed it for me. I soaked up the history of Old Parliament House and the energy of the new, and I thought, this is the place for me. Politics to me was the avenue to make lives better, more equitable access to healthcare, education, housing, and a basic income when life gets tough. So when the chance came to stand in 1996, while still studying arts law here at the University of Tasmania, I took it and I became the youngest woman elected to an Australian Parliament. Tonight, though, isn't for my full parliamentary story. Some of you might have been to another lecture where I've given that story in this very lecture room. So fast forward through the lumps and the bumps to March 2006, when I was appointed Minister for Health and Human Services in the Lennon government. People called health the poison chalice. I didn't see it that way. I wanted it, because this was my opportunity to make a difference for the homeless, for children in state care, for Tasmanians living with a disability, and for the sick needing care. So when is the health system not in crisis? Never. It's always relative to its time. It's part of the challenge in health. You only ever manage problems, you never fix them. And in 2006, health was on the front pages: ambulance ramping, long emergency department stays, elective surgery wait times blowing out. We've all heard it before. Demand was growing faster than our services could cope. Our pre-World War II babies and the post-war boomers were getting old and living longer. With older years comes more chronic conditions and higher demands on EDs and beds. Health inflation was pushing costs up. Work-life balance began to reshape workforce expectations. Bulk billing in general practice was under pressure. Aged care was creaking. Each year, health took a bigger slice of the state budget, and yet record spending never seemed to make a difference. Within 4 months of becoming Minister, AMA Tasmania, led by respiratory physician Professor Hayden Walters, called for me to either develop a plan for the Royal Hobart Hospital or quit. I listened. However, we took it a step further. And under the leadership of the Secretary of Health, Dr. Martin Forrest, we commenced Tasmania's first comprehensive clinical services plan with Dr. Heather Wellington commissioned to do the work. This plan was to look at the system as a whole, what services should be delivered and where. Fresh from reforming education, Dr. Forrest also began an internal reform aimed at stripping out bureaucracy through what was called a FIT campaign. This program was aimed at removing the inordinate layers of internal bureaucratic approval just to sign off a pair of shoes for a child in state care. Many of us would say it's time for such a reform to be brought back again, and we call it now within the AMA as the GROSS campaign, getting rid of stupid stuff. At first, Heather's brief was the acute sector, one statewide plan for all of our hospitals. Then our Deputy Secretary for Primary Health took me aside and said, Minister, if you're planning hospitals, we need a plan for primary health too. I've had a concept in my bottom drawer for years and I would love to share it with you. She was right. If you treat primary and acute as silos, you just shift the pressure point. So we brought the two plans together. Acute and state-funded primary care services under the one umbrella. Heather's team led the development of the health plan through months of painstaking consultation, talking to stakeholders service by service, listening to clinicians explain what they did in the community, matching it with data on demographics and demand, checking every service against safety and sustainability principles, and then being honest about what could endure. All services were judged against 5 key principles. Was the service safe? If we couldn't staff it properly, we shouldn't pretend we could provide that service safely. Was the service meeting quality standards? Was there sufficient throughput of patients to maintain the skill levels of the clinicians providing care? Was the service efficient? Could it be delivered at a reasonable cost? Was the service sustainable? Did it have the workforce to support it? Could care be delivered closer to home? And with changes in technology, in some cases, care could literally be provided in the home, such as with renal dialysis. So applying these principles and keeping true to the plan meant some hard decisions had to be made. Politically, that was never going to be easy, but I had the backing of the then Premier Paul Lennon to give it a go. And so the plan was launched. And soon after, all hell broke loose. Communities heard closure when we were arguing for safer care. Hospitals heard demotion when we were arguing for an integrated system rather than continuing to allow ad hoc growth of services simply because a clinician wanted to provide a service in a given location. I travelled the state defending the health plan because I believed in it, and I still do. I fronted packed halls and open rallies in Launceston, Latrobe, Rosebery and Ouse. The backlash of the LGH centred around it not liking its place in the hierarchy of hospitals, with the Royal Hobart Hospital noted as the tertiary referral hospital for the state. I'll never forget the pre-recorded boos and cheers played at the rally of 5,000 people in Launceston to help aid the atmosphere and rage against me. So much so it was even reported as boos and jeering. Then there was a time I was advised by my police protection that I should enter the Ouse Community Hall by the side door. I should walk on stage. I should deliver my speech, and then I should walk straight off back into the car to take me back to Hobart. Reasonable advice, considering my previous visit. On the left of your screen, you can see there are 2 visits to Ouse represented there. So on my previous visit on the left of the screen there, someone had thrown throwdowns or snappers at my feet, little firecrackers that pop on impact on the ground. I think because of my experiences in Papua New Guinea, I didn't flinch. However, I refused the advice of my police protection officer and I stayed until the last person left, knowing to do otherwise would only further inflame the situation. If you can't defend your decision, you should never have made that decision in the first place. If you're going to ask people to accept change, you owe them honesty and your time. At the Mersey, obstetrics no longer met the safety test, and HDU was being described as an ICU without the depth to back it. Vascular surgery was happening without a true ICU safety net. We argued in the plan for a different future: elective surgery, rehabilitation, subacute care, the services an ageing community most needed and could sustain. At the community rally against the Mersey changes, you could see on the slide, you'll notice that I'm actually not on stage as part of the panel, but local doctors were, by choice. They wanted to defend the plan and try to remove the politics. And I was asked to sit in the front row. That little red mark there is the indication of where I was sitting. You see, doctors like data, facts, and principle-informed decision-making. Most liked the Tasmanian Health Plan for that very reason, and they were invested in it. However, politics is politics. And while courage was shown by the local Liberal MPs, including Jeremy Rockcliffe, Brett Whiteley, and Senator Stephen Parry, who all supported the changes we were proposing in their backyard of Braddon for the Mersey Hospital, their federal Liberal colleagues did not. After all, there were votes begging. I happened to be on a bus in Florida on an American government leadership program when I heard on ABC's AM program via my mobile phone, Prime Minister John Howard announcing the federal government would intervene and save the Mersey Hospital by taking it over. All that hard work for nothing. Politics had won the day. The Howard government promised an immediate injection of $45 million to save the Mersey. Consequently, we sold it to them for $1. The Commonwealth was now the proud owner of their one and only hospital, and John Howard still lost the election. The new Health Minister, Nicola Roxon, and her department had no interest in running hospitals. It didn't take them long to ask us to operate it under contract, with a cheque accompanying the deal of over $60 million in funding per annum. We agreed. This arrangement continued until 2017, when it was handed back to the state with a cheque for $730 million from the Commonwealth to the state. Not a bad return. While some of the changes we made were never undone, such as obstetrics and vascular surgery being moved out of the Mersey, the problems that led to the suggested changes under the 2007 plan are still there, as is the politics. Staying true to the health plan was difficult in more ways than one. Leading into the state election in 2010, a generous philanthropist offered to fund a building to house an MRI machine used to diagnose cancer in the northwest. Off the back of this, the Liberals promised a cancer centre. The health plan was not recommending such a service in the Northwest, noting the difficulty to recruit the necessary staff, doctors, nurses, and others to run it. However, cornered by the offer of the private donation and the Liberals' promise, powers higher than me promised to support an MRI and cancer centre too. When my Chief of Staff came down to the office and shared the news with me, I burst into tears. The stress I had carried defending the plan for 3 years against immense public pressure came to the surface. Ultimately, once again, politics had prevailed. The Cancer Centre was subsequently promised a linear accelerator too by both federal parties in their election that same year, saving patients from having to travel to Launceston for radiotherapy. Now, how could you argue against that? A lesson for me of how politics is the art of the possible, not the perfect. Today, there are no medical radio-oncologists in the Northwest, and the cancer services are failing. In Tasmania, where you live still predicts how long you live. Levels of cancer, diabetes and heart disease are higher in lower socioeconomic communities like Bridgewater and Gagebrook, where smoking rates are higher, diets are poorer, and drug and alcohol consumption growing. The health plan tried to strengthen primary and community care and build a bridge to acute care through the provision of integrated care centres. These ICCs ultimately failed for lack of funding. Changes at community hospitals like Ouse and Rosebery were not about removing health investment in those communities, but redirecting that investment into services that would best support the primary care needs of that community, such as drug and alcohol services. We also knew investment in early intervention and preventative health measures was critical if we were to impact on the growing levels of chronic disease in the community. And while funding was always hard to come by for prevention, that did not stop me and the wonderful Dr. Roscoe Taylor, Director of Public Health in Tasmania, from driving national reform to add folic acid to bread flour to prevent neural tube defects like spina bifida. Or in Tasmania, we mandated the addition of iodised salt in bread to address population decline in iodine deficiency. And in my time as Health Minister, we also supported national initiatives like the HPV vaccination and the National Bowel Screening Program, driven by Tony Abbott as Health Minister. And proudly, Tasmania had the strongest anti-smoking legislation driven by my predecessor, David Llewellyn, which banned smoking inside pubs and clubs. We were the first state to do so. However, the battle to lower that life expectancy gap continues. The answers are complex and expensive. They relate to education, housing, employment, transport, health literacy, cultural norms, and so much more. This remains a challenge for all of us, and sadly, not enough emphasis is put into prevention. It is barely even spoken of nowadays. Not every reform was about closing, moving, or opening services. We also laid the digital foundations for a statewide electronic medical record, an EMR, a crucial reform if we are to become a genuinely connected health system. The first step was the digitisation of existing records that happened in my time. I can't believe 18 years on and that project is still not completed. I want to briefly touch on my reflections on leadership, including the role that gender can play. I hesitate to say too much on this topic, as really it is probably a lecture in its own right. However, suffice to say that from my personal experience and watching those around me, I make the following observations, noting that these are generalisations and not nuanced for the lack of time tonight. Women are said to be much better at collaboration than men. It makes sense. We are better communicators and networkers at one level. However, I believe that is true up to the point a decision is made. Then we stick to it. Men, on the other hand, are more flexible after a decision is made. Compromising comes more easily, just like bending the rules at home. I don't know about you, but if my sister or I wanted something, we went to Dad. Men are also better at keeping to the big picture, the helicopter view. Women have a tendency to get down into the detail too much, dotting every I and crossing every T. In some ways, we have to prove that we are up to the task, for we are judged more harshly than our male equivalents, that old glass ceiling. And while no fan of Margaret Thatcher, this view that I've just spoken of is epitomised in her saying to those waiting with bated breath for that favourite media catchphrase, the U-turn, I have only this to say: you turn if you want, the lady's not for turning. This was certainly me with the health plan. I found it easier to confront the crowds and defend a position than to negotiate a different outcome after the fact. To help break the them against us view of the community when it came to elements of the Tasmania Health Plan, it took my new Secretary of Health, David Roberts, negotiating skills to break stalemates with communities and bring about reform. Not perfect to the plan reform, but reform nonetheless. We achieved more by adjusting the path without abandoning the destination than we were by holding the line on principle alone. Compromising is not weakness, it's how complex reform crosses the line. So if you remember nothing else from this section, remember this: politics is the art of the possible. It is about balancing competing priorities. So frame your advocacy so a minister can say yes. Show how patients will be better off as a result, while anchoring your point of view in the principles of safety, sustainability, and equity. In 2018, I stepped away from Parliament and I stepped into motherhood. And quite unexpectedly, I found my way back to health reform from a different seat at the table. Becoming a mum was a great joy of my life. And after meeting my husband Ian and navigating IVF with a donor egg, our daughter Natasha arrived on Australia Day 2018. 12 months later, the CEO of AMA Tasmania knocked on my door and asked if I would consider applying for his role. I'd loved being health minister. I'd loved the challenge, the constant problem solving, and this felt like a way to keep contributing to Tasmania's health without standing at a podium every day. So in March 2019, I became CEO of AMA Tasmania, the second former Premier to hold the role after Doug Lowe, and I have mentioned to Jeremy Rockcliffe more than once now that I'm keeping the seat warm for him too. It was meant to be a part-time role that balanced work with a toddler. Then COVID arrived and part-time became 7 days a week, phones, briefings, media, and long calls with doctors who were hearing the awful news of their Italian colleagues dying overseas from COVID. Doctors were extremely worried about the consequences of this pandemic on patients and the people there to care for them. AMA President at that time, Professor John Burgess, argued early that this was an airborne respiratory disease and that our policy settings needed to reflect that. We worked closely with Public Health and Director Dr. Mark Veitch and Premier Peter Gutwin to close borders, protect schools and the elderly, require PPE and steady the system. As a consequence of the decisions government made, Tasmania was shielded from the worst of COVID lockdowns, although for many small businesses, especially in tourism and hospitality, the impact of COVID was still brutal. COVID was healthcare's great accelerator. Reforms we'd debated for years suddenly happened. Telehealth, for example, was rolled out nationally after years of states lobbying the Commonwealth, including when I was Health Minister. The Commonwealth's fear had always been an MBS blowout if access became too easy. COVID made the case that access mattered more than the perfect actuarial model. Guardrails went on, the button was pressed, and telehealth became part of the furniture. A patient in Smithton can now speak with a Hobart specialist without the need for a 9-hour return trip. Electronic prescribing was also brought forward about 18 months to make telehealth workable. The upside was obvious: speed and convenience, with scripts issued from anywhere in Australia. But as ever in health, a fix in one place creates a risk in another. A cowboy element emerged, a tick box platforms and rogue prescribers pushing medicines without proper GP assessments or tests, fragmenting care and increasing risk. But the answer wasn't to roll back digital, but to pair it with stronger checks and balances, tighter regulation, and data links back to the patient's usual GP. Hospital in the home moved from pilot to mainstream. Tasmania stood up COVID at home models using pulse oximeters, structured protocols, and phone-based monitoring, backed by nursing and medical oversight. Remote monitoring became normal with clear escalation thresholds and virtual rounds that helped avoid unnecessary ED presentations and ramping. Out of COVID at home, the government built care at home and now hospital at home, safe hospital equivalent care where people live. For the right patients, these models are at least as safe as inpatient care and on several measures safer, with fewer adverse events, lower readmissions, shorter stays, and less delirium, particularly for older Tasmanians. Safety depends on the basics done well: clear inclusion criteria, 24/7 escalation, robust remote monitoring, sound medication governance, and seamless links back to general practice. The lesson is simple. We can't build our way out with bricks and mortar alone. We must redesign where and how care happens. And with my Salvio board hat on, that doesn't have to rest on government's shoulders alone. Just as housing is delivered with NGOs, there's a clear role for private and not-for-profit partners to deliver high-quality healthcare at home, alone or in partnership with government. COVID didn't create our workforce crunch. It exposed it. We were already short of doctors, nurses, and allied health professionals. This shortage has worsened due to an ageing population, burnout from the COVID years, and a desire for shorter working hours. In general practice, it now takes more than 2 GPs to be trained up to replace one retiring one. Life as a GP is challenging with complex patients, heavier mental health plans, and very thin rebates. Both male and female GPs are seeking that work-life balance. They want to be hands-on parents. They don't want to be the always-on model of the old family doctor. This results in longer waits to see a doctor and higher costs, frustrating patients and constituents who then knock on the doors of their parliamentarians. This pressure fuels calls to expand the scope of practice of other health professionals and increase care options. From my political experience, whenever scope of practice is raised, predictions of doom follow and guardrails are added. Today's flashpoints include pharmacists treating UTIs, community paramedics managing patients, and nurses gaining authority to prescribe medications. In my time as Health Minister, these issues confronted me too. I signed off on optometrists being able to prescribe topical antibiotics for external eye infections against the fear of ophthalmologists. I introduced assistance in nursing against the ire of the ANMF, who argued only a registered nurse could diagnose a bed sore when showering a patient. And during COVID, pharmacists alongside GPs and nurse-led clinics delivered mass vaccinations safely under protocol. So today I'm asked, well, why, when you supported increased scope for non-doctor health professionals as a minister, how can you now lead an organisation that resists it? It is true, the AMA continues to argue against these moves. And working with doctors, I understand their frustration and their concern. They study for a decade to build their skills, which cannot be replicated by other healthcare professionals. I'm also concerned about the impacts on GPs if straightforward conditions are taken from their caseload, leaving them with the heaviest and most taxing cases. And then there are the risks that come with further fragmentation of care. Doctors want team-based care where roles complement each other, with the doctor remaining the critical person to diagnose and develop treatment plans. The question that politicians have to ask themselves is whether this is utopia. Considering my husband is a pharmacist, soon to be full-time teacher, an example of a burnt-out healthcare worker I spoke of before, lucky for me, I'm no longer that decision maker. Having said that, I question the ethics of one person diagnosing, prescribing, and selling medication. Protections need to be in place. We need also payment models that reward collaboration rather than the siloed activity that continues to happen around us. We need investment and commitment from both government and the private sector in IT that integrates across primary and acute sectors, public and private, which is a perfect segue to the final part of my talk. There are no perfect fixes in health. Yes, money helps. However, while increased funding can be beneficial, workforce constraints persist as competition to recruit nurses and doctors often leads to higher salaries without necessarily resolving staffing shortages nationwide. Today, you still walk into hospitals that have ambulances ramped, patients stuck in EDs, elective surgery being cancelled, waiting lists for outpatients blowing out. There are just simply not enough beds, and even with hospital at home initiatives, creating beds in the community. The private sector has the luxury of closing services that are unprofitable, as seen with Healthscope's closure of maternity services and St Helens Hospital, and the Hobart Clinic's recent decision to shut its mental health inpatient facility by the month's end. The public sector cannot, or at least not without strong community backlash and electoral consequences. So if I was Health Minister today, what would I be doing? Firstly, the Tasmania Health Plan has evolved into our Healthcare Future Plan, a plan not too dissimilar to my own, except not as many people know about it. Why has this plan had such a quiet entry? Well, two reasons. First, the hard decisions were made in the 2007 plan. Obstetrics, ICU and vascular surgery have not been reinstated at the Mersey despite political intervention. The three regions have settled into their roles as delineated in the 2007 plan and the role delineation framework launched by then Minister Michael Ferguson. Second, the inclusion of rural hospitals under the responsibility of the chief executives of the major hospitals in all three regions has brought acute and subacute facilities closer together. So while OO's beds remain closed, rural hospitals in New Norfolk, in Dover, Scottsdale, Deloraine and St Helens support major hospitals by accommodating patients in subacute beds for further assessment or recovery. It's also helped by further development in technology. We still have a long way to go to be anything like what I saw when I visited Seoul in South Korea back in 2007. They already had cameras in their ambulances that were beaming pictures back to the ED of the patient so the doctors were prepared when that patient arrived. They already had electronic patient medical records at the bedside and so much more. And while we await an electronic patient record in our hospitals, at least another 12 months to 2 years away, general practice has had electronic patient records for years. They are now moving into the world of artificial intelligence, assisting them in writing patient notes and referral letters. Some are already venturing into the AI receptionist used to make patient bookings. What is critical in this next stage of ICT development is that the public systems EMR talks to general practice programs. This way, general practitioners should be able to get real-time information on their patients while in the acute care system. Until data moves with the patient will keep falling through the gaps. So if you haven't worked it out by now, I'm a reformist and I get excited by change. I don't accept the status quo as ever being good enough. The world is changing and our health system must change with it. And while Dr. Google is good, it also has its limits and can leave you pretty sure you're dying of cancer. However, we're fast moving from Dr. Google to Dr. AI, who is a little more interesting. Artificial intelligence does not replace people, or in the case of health, doctors. It is best used as a tool, as a co-pilot. Emerging studies show that some AI systems have high rates of diagnostic accuracy, while unaided humans are often far lower. But AI isn't just a scoreboard. It's a signal that can make us faster and more consistent. And in the end, patients still need the human connection. They need the context, the compassion, and the trust. AI can assist by immediately flagging urgent findings, guiding non-experts in diagnostics and streaming data from wearables like this on me here to catch early signs of deterioration. And looking ahead, AI will shift us from reactive to proactive care with continuous monitoring, integrated decision tools and bedside guidance to prevent errors. It will also expedite trials and improve hospital management, but it won't replace judgment. We must train our future doctors differently. Yes, we must still emphasise physiology, as Professor Cobbold did, but we must also teach AI interrogation, strengthening statistics and ethics and fostering teamwork with shared protocols and real-time data sharing, with placements for our students in virtual care and hospital at home, and assessments that challenge those students to defend or reject AI advice. Our graduates will be skilled overseers, delivering safer, faster, and more human care. But remember, AI is a tool, not a boss. Doctors remain the accountable ones. As AI improves at diagnosing images, doctors will focus more on research and framing those questions, testing models, auditing results, and ensuring safety. They'll have the role of being the guiding eye around ethics, guiding genetics, data use, consent, explainability, and tool limitations. They'll be the leaders who are designing systems where humans and machines collaborate while prioritising patients, and they'll maintain the judgment and the relationships, managing complex cases, uncertainty, values, and end-of-life care. This highlights a need for continued strong knowledge in physiology, anatomy, and pharmacology. Understanding the system is essential to oversee it safely. So to prepare students for a health system shaped by AI, real-time data and new models of care, it is important that universities keep Professor Cobbold's passion of physiology and core science at the centre of teaching, but teach them differently. Students must learn to question AI, to spot where a suggestion fits a biology and when it breaks it. That means moving beyond rote learning to clinically integrated teaching, real cases, simulation, and decision support tools embedded in the lesson. In that world, doctors aren't replaced by machines, they supervise them, applying judgment, protecting safety, and leading teams to better outcomes. While robotic surgery is already here, and robotic housekeepers, as seen in the top right there, while a decade away, are coming, and I can't wait. I don't think, though, that it's too far off to imagine a world where robots can take your blood pressure, measure your oxygen levels, take and analyse your bloods, or even take a chest X-ray, all at home next to the bed. So beyond science fiction style of robotic care, what else could be a bold initiative to take us forward in healthcare in Tasmania? Well, my bold initiative is not new. It was seriously considered by former Prime Minister Kevin Rudd when I was Health Minister, and it's part of the advocacy of the AMA here in Tasmania to this day. That is, Tasmania be used as a pilot for a single funder. One payer, one plan, one system. The idea of a single funder is to remove the split between the Commonwealth and the state, creating one budget, one plan, and one point of accountability. Currently, Canberra funds GPs, specialists and medicines, while the state funds hospitals and community health. This divide creates wrong pocket problems, where investing in prevention or primary care might save the hospital system money, but the savings and costs fall into the different government's pockets. A single funder model allows money to flow to where it will make the most difference, whether that is keeping people out of hospital, funding hospital in the home, or supporting stronger rural services. It also simplifies the system, making it more accountable. Instead of competing priorities and buck passing, a single funder can commission services across the whole continuum of care. It can hold providers to outcome-based contracts and ensure funding follows the patient rather than the silos. It strengthens purchasing power, it reduces duplication, and it makes it easier to invest in shared infrastructure like electronic medical records or after-hours care. Most importantly, it gives Tasmania a clearer path to improve safety, access, and equity, because there is one steward of the health dollar with the ability to balance the system as a whole. There are risks, but they are manageable with a phased rollout. And in the end, the prize is a system that plans as one, pays as one, and performs as one, so that Tasmanians do get the right care in the right place at the right time. So was it all worth it? Yes. Tasmania is better off for the work that we put into the 2007 health plan. Our health system is better off for having had a premier with the political courage to let me, his minister, drive unpopular reforms through. I cannot imagine the mess we would be in today without that plan for our state. While the challenges persist, while there are no easy answers, the system is better integrated than it was. We are now moving into another period of austerity, and I fear that this will force the new minister, the sixth in my 6 years with the AMA, I might say, to face the realities of what services can be delivered and where. I would advise her to go back to the principles of safety, sustainability, quality, and efficiency. When we speak about Dr. Arthur Cobbold, we're not just honouring a fine teacher and dean, we're answering his enduring challenge. Think beyond the clinic, think systems, think society. And let me leave you with these 3 simple insights. First, politics shapes what is possible. You don't have to love politics to understand it, but if you want reform to land safely, sustainably, and equitably, you must understand why and how ministers make decisions. Speak in their language, recognise the pressures they are facing, and you will be a more effective medical leader or community advocate. Second, disruption accelerates reform. COVID moved ideas from whiteboards into wards, telehealth, hospital in the home, remote monitoring. Was it perfect? No. Was it progress? Absolutely. Real leadership is knowing when perfect is the enemy of good, when to adapt, when to compromise, and when to keep the core purpose intact, patient safety and access. And thirdly, the future belongs to collaborative, ethical, tech-savvy clinicians who can influence policy. From Dr. Google to Dr. AI, we'll need doctors who can interrogate data, who can lead teams across settings, who can guard ethics, and will still be able to deliver the human connection. Keep physiology at the heart of training so our doctors can oversee AI, not be overseen by it. And remember, everything we do is about the patients. All of us live with choices and trade-offs, and in health, every yes carries an instead of. A clinic here or a service there, a bed today or prevention tomorrow. If we keep safety, equity and sustainability at the centre, we can live with those choices and explain them to the people we serve. Arthur Cobbold inspired his students to think about how they could change medical systems. So my challenge is to you, as the medical leaders of tomorrow, as the clinicians, as policymakers, as community advocates, how will you help shape both medicine and politics to create a healthier Tasmania?
Thank you so much, Lara, for sharing your deep experiences and insights in such a generous way, and for your provocations and your challenge for us to think about the art of the possible. We do now have some time for questions.
Oh, thanks, Lara. Look, the thing that I most remember you for is cancelling the new Royal Hobart Hospital. I wonder if you'd just reflect on that in light of the problems and cost overruns with K-Block.
I'm so glad you asked me that, Brian. It's almost a Dorothy Dixon. In fact, I did say to someone coming here tonight, if no one asks me about the hospital, please do. I've said in the past that it was the lowest point of my time as health minister, the day that essentially I got a phone call to tell me that because of the global financial crisis and the deterioration in the state budget, a decision had been made that the new hospital would not continue. And then I had to go out and front the Tasmanian people and defend that decision. In my view, that decision should never have been made. We should have continued on with the new Royal Hobart Hospital as had been planned. But a little similar, like the public pressure we were under with the Mersey and others, politics had a large part to play, I believe, in that decision too. I still, in going through all the scrapbooks, I came across Brett Whiteley's alternative view that he put out there. He was the shadow minister at the time for health, and he believed you could build a brand new Royal Hobart Hospital by demolishing the medical school as part of the CPD block and the admin area down on the corner of Campbell Street and Collins Street, I believe it is, and that would be the saviour of the Royal Hobart Hospital. I remember ridiculing him at the time and saying that was his IKEA flat, pack box idea of a new hospital. But even though it was so ridiculous, those sorts of ideas were grabbed hold of by members of the community who were unsettled at the thought of the hospital moving from the CBD to the waterfront. Apparently, it was too far away from the CBD and it was going to hurt businesses. So the politics around it ended up being quite strong. And I think that it was an easy out when people said we can no longer afford it. The reality is it would have probably cost us about $1 billion to $1.5 billion. Now it would cost you at least 3, if not 4. And now we struggle. Having said that, it is awful going into the new Royal Hobart Hospital, well, going into the Royal Hobart Hospital. K Block is fantastic. K Block is good, but the rest of the hospital is an absolute mess. And even the new development of the emergency department is less than ideal. We're going to end up with an emergency department that has to be expanded because demand is growing so strongly. And it's going to be an emergency department over, I believe, 3 levels, which is not how you run emergency departments, but it's all they can do. Essentially, we should be abandoning the current site and building a brand new hospital somewhere else, preferably close to the CBD, but it doesn't have to be.
Thank you, Lara. I might go to an online question from Lynette Taylor, who talks about regional and remote healthcare. And her question is about how can remote and regional services be made more sustainable and cost effective, or do we need to accept that where we live will impact on our capacity to engage with services to live long and healthy lives?
That's a very interesting question, because when you live in rural Tasmania, you live in rural Tasmania for a reason. You love it. You don't want to be in a city. You don't want to be closer to services, but you still need health services to keep you healthy. And we have an obligation to look after Tasmanians no matter where they live. But that is why it is important that we do properly plan our services. And in any planning, you're looking at how you can provide as many services as possible safely in a local community. But you will also always have to accept that there will be some services that cannot be sustainably provided in a local community. And that does mean that you will at times have to travel. But I have to say, thank goodness for St Helens Community Hospital, because there's a lot of use of that emergency department with the growth in the activity of mountain biking that's happening around Derby and places. So I do say we need those hospitals as well.
Thank you. I'm looking for questions in the room. I can see over here on the right.
Hello, Lara. You might be able to help me. As a GP who has a bit of a burnout and doing other things now, I found that having done 25 years of general practice in the very available doctor mode and doing nursing home care and palliative care, I then stepped into emergency during COVID and then went back to look, well, maybe I'm very experienced and I can do locums. And it might fall into this bracket of what you're calling with the whole system, one payer thing. But I find that I can work in general practice and earn perhaps a half of what I could earn if I worked at an urgent care clinic with no complex cases, 5 minutes away from an emergency department, where any GP worth their salt could work in that urgent care clinic. And if I go and do a locum at Bruni, I get half the amount of working in an urgent care clinic. And it really doesn't make sense that the federal government is putting so much money into urgent care clinic when they probably just need to stick with their plan of making a Medicare rebate sustainable so that we can actually then charge students what they can afford rather than charging them $90 out of pocket, which they can't afford. We could bulk bill people under 16, people over 75, and the people that can afford to pay might be able to afford to pay. So it just doesn't make sense.
Yes, look, you've really opened up a can of worms for general practice in that question in that regard, because again, it's so complex. And it's an example of what I talk about in health, that you see a problem emerge here, so you put resources there, and all that does is create a problem over here. So you put resources there and it blows up over somewhere else. There is no perfect solution in health ever. It is always about managing these matters. So should we have urgent care clinics or not? I think they're here to stay. There is a role for them, but what they have done is absolutely created this inequity now between general practice and the urgent care. You will hear some within our emergency departments will say that the urgent care clinics have made very little difference in terms of the demand that's coming through their front doors. But when you talk to mums and dads who have gone to an urgent care centre on the weekend and they've waited 10 minutes, half an hour, they would have been waiting 4, 6, 8 hours if they'd been to the Hobart, Royal Hobart, and their GP is not open on a weekend, or their GP doesn't have those extended hours. And of course, the demise of GP Assist is also part of that problem, because general practice were offering, in a sense, extended hours, either physically. There were a number of general practices with longer hours that may have reduced those hours now because of urgent care centres. So have we in fact got more hours in the community? Arguably not, in terms of general practice care. But as I say, look, it's just so complex. But in terms of the AMA, those issues around the rebates is critical. And that is something we argue and advocate for very strongly in the powers and the halls of Canberra, to say you must look at what you're doing with general practice, because people are not choosing general practice anymore either to go into. The lucrative life of a doctor in the hospital, where you can earn maybe twice as much as what you can in general practice, means it's attractive for the younger doctors to stay there. And the work-life balance you get, the parental support you get when you're in a medical facility that's government owned, means that general practice is less attractive. The single employer model is addressing some of that in the training of our doctors when they're registrars in general practice. But as I say, what you've opened up there is probably a lecture in itself. But yes, it's important nevertheless. And a single funder model would enable us as a state, at the state level, to be able to understand and balance all of those elements. A simple solution, of course, is an NHS model of salarying, making all GPs salaried doctors. But that's not going to work either. That's a massive cultural shift and not necessarily the right answer either. There are genuinely people out there who love being a private business. They don't want to be a government employee. They want to have the freedom of being an independent operator.
Thank you. Peter Brooks over in the middle.
Thanks, Lara. That was absolutely fantastic. Would you like to comment a little bit about prevention? Because we, like most health systems, spend, 10% of our total healthcare budget on prevention. And two things, like if we actually had a sugar tax in Australia, or if we had sensible labelling for the food, so that people we didn't have this epidemic of obesity. And the problem is there, as you point out, is that the where you win in that is 10, 15, 20 years down the track.
Yeah.
How do we get across that?
Thank you, Peter. That issue of investment in prevention is really important, and it's so difficult when you have, as a health minister, the problems in the acute care hospitals demanding more and more funding, to then be able to release that funding to put into prevention and preventative care programs is very difficult, and yet it is what is required. It can have a massive impact. Some of it is also about having the political courage to make decisions as well. So things like with smoking, I think the banning of smoking in pubs and clubs was a really critical decision that was made that helped once again to change the culture of acceptance of smoking. No longer could you be inside a venue talking to your non-smoking mates, puffing around them and feeling like it was all acceptable. Suddenly you found that you were ostracized, that you were the one that had to leave the venue. You had to stand out in a bitter winter night outside, puffing on your cigarette while your mates were still inside, enjoying the warmth of that environment. So it started to shift behaviour in that regard, and I think it did have a big impact on smoking. But today, alcohol is a big problem in terms of underpinning reasons behind increase in chronic health conditions. And yet we don't have any political party that is willing to take on the alcohol industry and actually start bringing in reforms such as a volumetric tax on the level of alcohol in a product. So the more alcohol in a product, the higher the price of that product, as another way of using price to discourage drinking when we know that alcohol is damaging people's health. So there's it's a mixture at times of the need for money to invest that makes it difficult, and then there is a mixture of political will being required to drive legislative change that would fundamentally address those issues. I might also say we need to do more in dental care, that we know the link of deterioration in people's health is often related to their teeth and the health of their mouth. And yet again, that is an underfunded part of government.
Thank you, Lara. I'm going to go to an online question, which is again around prevention, but perhaps the workforce element of that would be useful too. But Carolyn Gutteridge agrees that we need to spend funds on preventative health measures. And while realising that finding health professionals is increasingly difficult, from a chronic kidney health perspective, patients in the north and northwest do not have access to a renal dietitian or a renal pharmacist. And these professionals are integral in keeping patients off the expensive home or in-centre dialysis. How do we get politicians to recognise prevention is better than expensive hospital care?
Yeah, very good question in relation to that as well. And it comes down to workforce and how you attract people into the Northwest to be able to provide those services. Again, it's complex. It's not always money alone. In terms of the hospital system, we pay our doctors more to work in the Northwest, and yet we still struggle to get Australian trained doctors to work there. Our hospitals in the Northwest are very reliant on the wonderful services, I have to say, of our international medical graduates who we could not run our hospital system without nowadays. And they also rely heavily on their very expensive locum model as well. So if it was money alone that got some of these professional people to move to the Northwest, in theory, we shouldn't have a problem in attracting people. So we need to understand that it takes more than just that. But again, the plan, going back to planning, looking at the data, looking at the demographics, looking at what services are required where, looking at how you can provide those services using technology as well. So it shouldn't necessarily depend on that skilled professional, health professional living in that community. If we use telehealth well, if we use ICT well, we should be able to deliver a lot more services closer to people's homes. But there is also a reality in Tasmania that we do need to be prepared to travel. We can't, with 500,000 people, provide all services in every region. There are some services it's just purely impossible for us to be able to do that, not always to do with money, but to do with a skilled workforce willing to live and work there. And the question just one, wait, I think the gentleman behind us.
With the robotic surgery, it's just been introduced to the LGH. And also they did advocate that if someone was injured in Antarctica, that would be a method of introducing surgery there. Do you think in more remote places like the Northwest Coast, that could be used from Launceston or Hobart to ameliorate that lack of surgery expertise, but having the nursing backing to enable that, please?
Look, this is where I get really excited by technology and where the world is going. There is so much more we can and should be able to provide in local areas, in local places like the Burnie Regional Hospital, with the backup support of a specialist, not just at the Royal Hobart Hospital, but at the Royal Melbourne Hospital, or indeed at Harvard University Hospital. There is no reason why in this connected world we can't be better supporting those local doctors to provide care in a local region and using robotic technology to do that now. The big factor that prevents us from doing it is the cost. And that's why here we are 18 years later from me starting to digitise a medical health record, we still don't have an electronic medical patient record in Tasmania. I find that extraordinary.
I'm glad you mentioned costs, Chris Merridew. The question is, it is often said, as things are, that there is as much more bureaucratic people in the health structure in this state than there are actual hands-on at wards. Be this the case, how was it in your day and your ratio of bureaucratic to hands-on the wards or medical staff, and how you believe the AI may perhaps reduce this factor? Thank you.
Great question. Again, I think AI is not going to replace people, but it is going to make people a lot more efficient. I'm using it now in my everyday work with the AMA. Once upon a time, it took me half a day to write up a media release. Nowadays, I can put the key themes into AI, ChatGPT, and say, write me a media release. Within seconds, I've got more than the bare bones of the media release nowadays. So just in terms of my own efficiency, I can see the difference that AI is making for us. Does that mean we need a smaller bureaucracy? The answer to me is no. I can't say that today from the AMA or yesterday as Health Minister, I can really tell you what the health bureaucracy looks like and how it's made up and where they are. But what I can tell you is that I get very frustrated because there's never enough of them. When I'm trying to help a doctor crack through the problems that they're facing in the hospital and I need someone in HR to help me do it, I've got one person to rely on. When I'm trying to crack through on industrial relations matters, there is one person who has two other people, I believe it is, in his team to help me crack through in those industrial relations issues. So it's very easy for us to point the finger at the bureaucracy and say, there's too many fat cats. All we need to do is cut the bureaucracy and the hospital system will be far better off for it. I don't actually think it's a zero-sum game like that at all. If we undermine our bureaucracy too much, we won't have the investment in the policymakers that are required to actually make sure that your systems are working properly, that they are modernising, that people are supported in the workplace as well as patients as well. So I've never been an advocate for just cut the bureaucracy and that will save you the problems. In fact, cut the bureaucracy and you'll find it 10 times worse in my view.
Thank you. Look, I would now like to invite the Arthur Cobbold Memorial Lecture Committee member and actually a former student of Professor Cobbold, Dr. Rob Walters, to provide the vote of thanks. Thank you, Rob.
Look, when Elizabeth Cobbold, the widow of Arthur Cobbold, was expressing to the committee her wishes about what this annual event was to be, she expressed the wish that it should present information and stimulate discussion about matters that would improve the health of every Tasmanian. And I can't think of a presentation, the presentation we've heard tonight, that hits the mark better than the one we've heard from Lara tonight. And thank you, Lara, very much. You mentioned and you quoted that lovely little bit from Arthur about how he spent half his time arguing with the health ministers, because he didn't only do his role at the university, he was widespread out in the health community. And I as you were talking, I couldn't help but see you and he sitting having discussions, having known the man himself. And perhaps for those that don't know much about Arthur Cobbold, the man, let me just share a little bit. Arthur was raised in East London from humble beginnings, and went to a Jesuit school and then studied accountancy. He then went into the army, from which he says he was thrown out. He was in fact invalided out, and obtained a chemistry degree. And during that time, he did some teaching at some schools, and then obtained a degree in physiology. During that time, however, he was also becoming involved in local politics, and was developing an interest in council work. That transgressed into the Conservative Party politics, and in the early 60s, Arthur came to a bit of a crossroad. He was involved with people even then of the status of Churchill and Harold Macmillan. He was very instrumental in campaigns for Edward Heath, who was a Prime Minister of the UK, and indeed Maggie Thatcher. And he was apparently earmarked to take over a seat in Conservative politics, but in 1964 made a very rash decision at the bequest of Cyril Barnett, who was the initial dean of the medical school here, to come to Tasmania and be the foundation physiology professor and to start the physiology department here at the Tasmanian Medical School. So in 1964, he and Elizabeth came to Tasmania and indeed got involved. And in 1970, Arthur was appointed as dean of the medical school, a role he held for 13 years, a record time for a dean of medicine. We all knew him as a gruff, very opinionated gentleman. We never called him Arthur. It was always Professor Cobbold. I never saw him. I didn't ever see him, I don't think, without a tie on. He was a raconteur par excellence, and his speeches at medical student dinners were something that was looked forward to. And indeed, many of us found out that he knew a lot more about what was going on and at those speeches than we had previously known. But he also got involved in other things regarding health in Tasmania, as was hinted when Lara made that quote, and indeed was the chair of the Royal Hobart Hospital board, for instance. I think he's probably the only chairman, Lara, that ever called for cigarette breaks to go outside and have a fag, because he was an inveterate smoker until the later part of his life. But he contributed an enormous amount to Tasmania's health system. He says that his proudest achievement was indeed the medical school, and I can attest to the fact that the Tasmanian Medical School is indeed held in high regard throughout the world. And when I've been over in the UK doing locums when I was a young doctor, people would say, "Oh, you're from Tassie. We like Tasmanian graduates because they've got such a broad experience rate, et cetera, et cetera." So the school he created has got a very good reputation. And I think coming back to what you were talking about, he would have loved tonight. He would have loved to debate it with you. Health policy is not for the faint-hearted, and you'll never please everybody, as you've demonstrated. I can remember your 2011 health plan, 11. health plan because as a GP, I was involved in GP politics at the time, and you brought, as you said before, the acute primary stuff together, and that has carried on as well. And so I think there's enormous examples, if we look at our system now, that have got the Giddings hand on it still. And I think that's a credit to you, as is the fact that you have not only, when you got out of politics, remained involved in the health system, as you are with the AMA, but you and I, as you know, are involved from time to time in various campaigns and things. Your understanding and your wisdom with regard to the politics of it all is enormously helpful. So thank you very much for tonight. It's been a fabulous presentation.
I would also like to extend my gratitude on behalf of the university and the Tasmanian School of Medicine to the Arthur Cobbold Memorial Committee members for their work on this event. So thank you for that. And should you wish to share this conversation with your friends, families or colleagues, this evening's talk is now available as a video on our Island of Ideas website. And shortly it will also be available as a podcast. And you can find the details of that on our Islands of Ideas webpage. And while you're there, please register for our next talk, which is about ageing well at home, where 3 experts explore how we might create conditions that allow people to live safely, independently and with dignity as they grow older, from housing and neighbourhood design to community services and support systems. So please join me and thank once again our honoured guest and speaker, Lara Giddings, AO.